afternoon again. I know it's been a busy program, and I see that most people have gotten some lunch and have a seat and enjoying that. To stay on time, that's an important thing for us, and I respect everybody's time, so we want to keep moving this along. I think our next section is we're going to focus on a little bit of renal vascular disease, and then one talk by Dr. Cuozzo on the gender differences and outcome differences in people with PAD and vascular disease. So our next speaker is Veronica Osteen. Is Veronica in the house? There you are. Awesome. And Veronica's been with me now, I think, 7 years? 7 years. See, I got that right. And she's going to talk a little bit today about renal vascular hypertension and when do we need to fix this? When do we need a stent? That's the critical issue. So thank you.
Thank you. So we're going to talk a little bit about renal vascular hypertension. So I like this little cartoon because I like to keep things really simple with my patients, and this is how I explain it to my patients. When there's stenosis in the renal artery, the kidney's just like, the blood pressure must not be high enough. Let me fix that. And so the kidney puts out hormones, renin and angiotensin, which creates a constrictive action throughout the body, and we see hypertension. Some facts about renal artery stenosis: it is the most common cause of secondary hypertension. It is often seen when we see onsets of hypertension under the age of 30. The two most frequent causes of renal artery stenosis are atherosclerotic disease and fibromuscular dysplasia. So what are indications for stenting? They are uncontrolled hypertension, which we define as being on 3 or more blood pressure medications and still having an uncontrolled blood pressure. So if you have a very high blood pressure, but you only take 1 or maybe even 2 medications, we're going to tell the patient, let's get back with your primary, let's figure this out, and let's maybe treat this if you come back to us on 3 hypertension meds and it's still uncontrolled. We also sometimes stent in patients who have recurrent CHF or pulmonary edema. And then the other main consideration is preservation of renal function. So when we see somebody who has bilateral renal artery stenosis, and this is at risk of affecting their kidney function, if they have renal artery stenosis and this is their only functional kidney. So, I have patients who have already lost 1 kidney, and then they have a 60% lesion in their remaining kidney. We're going to be a little bit more protective of that kidney. And then if we see renal artery stenosis and nephrology is, letting us know that this patient's renal function is suffering and they have an unstable GFR, we do stent for that. Some things to think about and remember when doing renal artery stenting is that technical success doesn't always indicate clinical success. So you can have a perfectly placed stent, there's no more stenosis, the kidney is getting good blood flow, but it doesn't mean they get better. So that sometimes happens. There are complications that happen. There can be dissections, arterial thrombosis, and in about 25% of patients we see restenosis that eventually has to be retreated and causes a problem again. Couple case studies here. So this was a 78-year-old male. He recently started seeing nephrology, who is actually who referred him to me. He was new to nephrology. His last creatinine was 1.3. His blood pressure was well controlled in office. It was 122/70. Currently, he takes only lisinopril. He is on aspirin and a statin. This is his ultrasound. You can see that he has bilateral greater than 60% renal artery stenosis, but his resistive indexes are okay. His kidney sizes are okay and symmetrical. We start to get worried when we see one kidney that is definitely getting smaller than the other kidney. That's a problem. So I had a phone conversation with nephrology, and with this patient we decided to follow him. We'll watch him closely. He may end up needing stented at some point in the future, but right now he's stable and we're just going to follow him. This patient was a 45-year-old male. I had been following him for at least a year. When I saw him back in office, the notes from nephrology indicated that his renal function was decreasing. He was now on 3 blood pressure medications, and he reported that his blood pressure was all over the place. Sometimes it would be controlled, but sometimes it would be 170 over 100. He had not achieved any type of blood pressure control. So his ultrasound shows us high-grade stenosis on both sides. I think what I was most concerned about was this greater than 60% with a velocity of 779 on the left side. So I did talk to one of our surgeons, and he was stented. He now actually has bilateral renal artery stents. Some other things that I learned researching this is that really we should never do renal artery stenting prophylactically unless it's, like we said before, to preserve the function of a solitary kidney. Otherwise, we need to treat renal artery stenosis when we have to, not just because maybe we should. The CORAL trial showed that revascularizing by renal artery stenting did not significantly slow chronic kidney disease or reduce the incidence of cardiovascular outcomes versus treating these patients medically. So my takeaway from this is to medically optimize your patients first before you stent them, but send us those patients. If they have renal artery stenosis, let us follow them. Let us see if they do need to be stented or not. But not everybody with stenosis needs a stent. Thank you.
Hi, good afternoon, everyone. My name is Dr. Tatyana Joab. I'm a nephrologist, and I'm here to talk to you about the impact of pre-existing conditions on renal vascular disease. I have not used this before, so bear with me. Hang on. Which? Green? Green. I have no conflicts. So let's begin. What is renal vascular disease? It's a variety of complications that affect the arteries and the veins of the kidney. This affects the blood circulation of the kidneys. It may cause damage to the tissues of the kidneys, kidney failure, and/or high blood pressure. I'm not going to scare anyone with renal physiology, so you can ignore the glomeruli in the corner, but I just wanted to show the gross picture of a kidney, so you can see the artery, the vein, and you can ignore the ureter as well. But renal vascular disease typically just impacts the renal artery or the renal vein. And I just kind of broke it down into these little sections so that it's pretty easily digestible. So commonly, renal artery stenosis, you just heard a bit about that. You can have renal artery aneurysm, arthromembolic renal disease, renal artery thrombosis, and then on the venous side, you can have renal vein thrombosis. And so for each of these, I'm just going to tell you what it is, how does it present, what causes it, how do we find it, and how do we fix it. A lot of how we fix it has to do with sending to vascular surgery, so I'm not going to go too detailed into that, but we'll touch on it. So renal artery stenosis, the most common form of it that you would see would be atherosclerotic, and that's going to be more than 90% of them. The presentation, as you all kind of commonly know, is that hypertension, resistant hypertension. Patients are on 3 different agents. It has to include a diuretic for us to classify it as resistant. And then the reason that you have this is you have an ischemia-induced RAS activation, so that would be your renin, angiotensin, aldosterone syndrome, and then that leads to progressive endothelial dysfunction, AKI, and then it sometimes can worsen when you start RAS inhibitors, so the ACEs and ARBs. So how do you find it? CT angio, MRA, you can do Dopplers, which is technician dependent. So sometimes you might have one technician say that they see stenosis, and then another one who's a little bit more experienced in it will see it and they say, no, it's not really significant. So there's always that question there, and of course renal angiography is how you can get a diagnosis. A lot of my slides are gonna have CTA as a diagnostic tool. I implore you, if their GFR is under 30, just ask us first. We want the diagnosis just like you do, but we want to mitigate how much CIN we would get after. So what is renal artery stenosis? The atherosclerotic version. It's an atherosclerotic process. Just like any other vascular bed, you have plaque built up. What causes it? This isn't going to shock you. Smoking, hypercholesterolemia, diabetes, metabolic syndrome, overweight, cardiovascular disease, hypertension. And how do we fix it? Smoking cessation, of course, antiplatelets, statins. And typically the patients who do not tolerate ACEs and ARBs, they tend to have more hemodynamically significant lesions, so you're going to send them across to vascular, and they'll monitor and stent as needed. Another form of renal artery stenosis you can get, it would be with fibromuscular dysplasia. And I was really pleased when I was walking around to see that there is a post out there on fibromuscular dysplasia, so you'll see a lot more information on that out there. The presentation is the same, finding it is the same, but these patients are different. So this is a non-atherosclerotic, non-inflammatory disease, typically young women, childbearing age. It's often sporadic, 10% are familial. You can have some rare disease associations. So these are the types of diseases that you probably read in textbook, and I think I've only seen 2 of them in real life, but you'll have like your neurofibromatosis, tuberous sclerosis, Ehlers-Danlos, Williams-Turner syndrome. There is a small association with smoking, so of course fixing it, we want to stop smoking. Angioplasty versus stenting versus surgical correction, again, that's up to the vascular guys to kind of take a look at and decide. RAS, of course, RAS inhibitors, and then antiplatelets are typically not really used beyond that post-angiography stage, and there's no real use for statins in these cases. And then, of course, you have Takayasu's arthritis, which is extremely rare. I don't even have a prevalence on that for you. This is a rare inflammatory disease that affects the aorta and its branches, so that includes the renal arteries. These are going to be a woman, 10 to 40 years old, age as far as their ages, and this is predominantly in Asia. The mechanism is not well understood. There's some cytotoxic, I'm sorry, I can't see my slides, bear with me. Cytotoxic lymphocytes that can cause vascular injury, and then you can also have B lymphocyte involvement as well. And with most inflammatory disorders, we tend to kind of throw glucocorticoids at them. There really isn't much data on which steroid-sparing agents are better, and then endovascular intervention is usually avoided during active disease states. Next, we have renal artery aneurysms. So an aneurysm is an aneurysm. It's a bulging or weakened area of an artery to a kidney. Most of them are small and incidentally found. So the presentation is incidental, unless it ruptures, which then you'd get that hypertension, flank pain kind of syndrome. But for the most part, there's another diagnostic procedure going on, and they're like, oh, wow, there's a renal artery aneurysm. You find it, CT angio, you fix it, vascular surgery. Then we can have atheroembolic renal diseases. So what this is when there's an atherosclerotic plaque that breaks off and embolizes distally, and that can result in partial or total occlusion of multiple small arteries, or the glomerular arterioles, and that can lead to tissue or organ ischemia. This is going to be iatrogenic. So someone who so you find this with history and physical. There's no imaging for this one. This is someone who just recently had an angiography, they just had CT surgery, they just had thrombolytic treatments, anticoagulation, sometimes it's spontaneous. And it's going to be like an embolic shower. So you would see signs of it in the skin, whether it's blue toe syndrome or levator reticularis. You can have some mesenteric involvement as well, mesenteric ischemia, GI bleed, pancreatitis, or you can have CNS involvement. So you can have TIA, visual disturbances. Fixing it would be statins, antiplatelets, smoking cessation, good blood pressure, and diabetic control. And now we're coming to renal artery thrombosis. So thrombus is a clot. So this is a clot that is formed in the renal artery. This one is often misdiagnosed and can progress to infarction. The presentation, this one would kind of be your hospital presentation. You're not going to see this as insidiously in clinic, but you're going to have AKI, abdominal pain, flank pain, fever, nausea, vomiting, hematuria, hypertension. It's a little bit dramatic. And it's going to be caused from thromboembolic events. So you can have thromboembolic events or in situ thrombosis. So your AFib, cardiomyopathies, endocarditis, artificial valve thrombi can lead to it. Or you can have patients with hypercoagulable states like hereditary thrombophilia, antiphospholipid syndrome, nephrotic syndrome. Or it can also happen sometimes if there's renal artery injury. So with dissections, trauma, Marfan's, polyarteritis. How do you find it? Contrast CTs, MRIs with GAD, and you can also sometimes get high LDH in the serum as well. You fix it, thrombolysis, anticoagulation, thrombectomies. And then we have renal vein thrombosis, which is the formation of a clot in the vein. Again, AKI, flank pain, hematuria. Sometimes you can have it embolized to pulmonary embolism as well. And these are going to be caused, again, in that prothrombotic state. So that's that Virchow's triad kind of thing with the hypercoagulability, stasis, and endothelial injury. And I kind of broke it down into sections. So hypercoagulability is going to be nephrotic syndromes, malignancies like renal cell cancers, pregnancies, OCPs, steroids, coagulable disorders. We saw it quite a bit with COVID-19. Stasis would be like compression of the renal vein by an adjacent structure. So if there's a tumor in the area and it's causing that poor flow, and then endothelial injury. So this could be like trauma post-kidney biopsy can also lead to this. Again, diagnosis, CTA, MRV. Doppler ultrasounds are really helpful for transplant kidneys because they're, superficial, a little bit easier to see, not hidden behind the ribs or the liver and all of that. But it's not really a good choice for native kidneys. And then this would be anticoagulation, local thrombolytics, IVC case by case. And these are my citations, and thank you so much for your time.
All right, thanks again for the privilege to be here. It's a great case. We're going to talk a little bit about gender differences in the treatment and outcomes for peripheral arterial disease and vascular disease. I have no disclosures. So peripheral arterial disease in women, PAD affects greater than 200 million people worldwide. In 2045, it's going to probably rise by more than 50%. And in 2012, the American Heart Association made a call to action to specifically address gender-related disparities in PAD, noting the need to raise clinical awareness, focus treatment plans, and expand research efforts. However, more than 10 years later, PAD is still underdiagnosed and understudied in women, despite recent findings suggesting an increased prevalence in women. And so this discrepancy we see in PAD is a complex interplay between biological, societal, and clinical factors. The biological we cannot change much, but we need to recognize. Societal and clinical areas we probably can do a little bit better in. The breadth of my talk today will go over the prevalence initially, which we see generally a higher prevalence in men of PAD, but it equalizes after menopause. Clinical presentation and symptoms are different. Like my case this morning, my patient did not have exertional claudication. She kind of had overall limb dysfunction and kind of lifestyle dysfunction. So the one thing that I have learned in my practice and over life, and probably been helped by a wife and 3 daughters, is listen to your patients and really hear what they're saying, because they're not going to tell you the same thing that men tell you. Men is pretty straight and simple. Calves hurt, can't walk, need help. But women are different. They're going to tell you about lifestyle. They're going to tell you they don't do this stuff anymore. Like my patient's mother this morning, she was like, she never leaves the house anymore. And it's a problem. Diagnosis, ABIs may be less sensitive with asymptomatic disease. Therapy in women has been a little not adhering to some guidelines for some reason. They have lower rates of surgical intervention and higher rates of endovascular treatment. Responses to therapy is also different. A walking program, it's been seen, doesn't work as well in women for some reason. So getting to the epidemiology, in the United States, an estimated 4 to 10% of adults over 40 have symptomatic PAD. ABI and its cutoff levels affect these estimates because ABI is essentially how we diagnose it. Women with an ABI of greater than 0.9 and asymptomatic may have unrecognized PAD with associated cardiovascular and mortality risk. And this women can have traditionally asymptomatic PAD. The prevalence of PAD in women is underrepresented, especially in those considered disabled. The Women's Health and Aging Study was a study done over 20 years ago, and it reported on disabled elderly living around Baltimore, Maryland. It was a study done by Johns Hopkins. Only about 6% of the participants had been told by a doctor that they had PAD, when in reality, when they measured all these ladies, 35% had it as determined by ABI. And the interesting thing is that most didn't complain of exertional leg pain. And so what they found was that asymptomatic PAD was measurably and independently associated with impaired lower extremity functioning. So they asked these ladies questions like, how many times did you leave your home last week? Or can you climb 10 steps without resting? Do you ever walk a quarter of a mile? And how many blocks do you walk in 1 week? They also tested them objectively by simple things like a 4-meter walk, chair stands, or balance tests. And what they found is that these asymptomatic PAD had significantly lower functioning levels by these measures. So what it showed is that asymptomatic PAD can affect more than 1/3 of community-dwelling disabled women, and these screening questions to identify PAD in the community should probably be for women more limb function-centered or lifestyle-centered rather than purely symptom-based. Clinicians should consider screening ABIs among community-dwelling disabled older women, and clinicians need to be cognizant of the independent association between PAD and this increased risk of cardiovascular morbidity and death. A little bit about the pathophysiology. It's not clearly understood, but we do have some hints. So we know that vascular endothelial dysfunction represents an early step in the formation of atherosclerotic plaque. Reduced nitric oxide bioavailability and impaired endothelial function is seen in menopausal women. Estradiol has been shown to improve endothelial function in postmenopausal women. And also estrogen has been shown to have some anti-inflammatory effects as well. Now, relationships between hormone therapy and PAD outcomes are inconsistent. I mean, some show improvement, some show worsening. When you look at risk factors compared to men, it seems that the risk factors take a greater toll on women in terms of increased risk. So we know that smoking conveys a 10-fold risk for women for PAD. Women with diabetes actually have a greater risk for overall atherosclerotic disease than men do. Women with hypertension, it's more common in women with PAD, and their claudication is more pronounced when they do have it. And then women with PAD have a higher prevalence of hyperlipidemia. When we talk about non-traditional risk factors, there can be pregnancy complications like preeclampsia, which will predispose you to increased risk of peripheral vascular disease. Rheumatoid arthritis affects predominantly women, and we know that it has a significant risk increasing for PAD. In women with chronic kidney disease, PAD is 50% higher in women, more than men. We know that women with PAD have greater depression and kind of mental health issues. Osteoporosis is also closely linked to PAD. And then when it comes to socioeconomic and education status, the lower the status, it seems like the increased risk for PAD. Outcomes as well are a little bit different. We know that women with PAD have higher rates of above-knee amputation. But the one thing that is equal when it comes to critical limb-threatening ischemia, rest pain, non-healing wound, the mortality associated with that is similar in men and women. And I think that speaks to just the high mortality associated with critical limb-threatening ischemia and the significant problem that it is. In terms of treatment medically, we see that men are more likely to get antiplatelet medication. Women get less benefit from a supervised exercise program in terms of claudication onset time. Rates of endovascular treatment are essentially equal in men and women. Long-term patency rates of surgical bypass, though, has been seen to be lower. They have equivalent limb salvage rates despite more multi-level disease in women. Women have higher rates of bypass failures and in-stent thrombosis. And women have a higher risk of endovascular access site complications. The last few may be because of, as Dr. Harris mentioned, the actual size, the average size of the artery in females is smaller. So what about peripheral vascular interventions? In vascular bypass grafting, it's been shown that female gender can be an independent risk factor for wound dehiscence and soft tissue infection. There's actually lower patency rates for bypass grafts on women on hormone replacement therapy. In this specific study, there was decreased patency rates in women for percutaneous iliac interventions, especially when hormone replacement therapy was used. And in a final study, it was showed that in both men and women undergoing infrainguinal endovascular interventions, the outcomes were equal despite increased disease severity in women. So this is a case. This is a lovely 65-year-old female patient who I kind of affectionately call my birthday patient. And it's because 2 years ago, she showed up on my birthday in the ER with a cold leg. Her right foot was discolored, it was numb, it was weak, it was cool. She had no history of peripheral vascular disease ever. She did have this surgical history of a bunionectomy, and someone rightly got an ABI before bunionectomy, and her ABI was essentially normal. Past medical history included hypertension, hepatic steatosis, atrophic left kidney. She did not have chronic kidney disease. She never was a smoker or tobacco products. She had no history, family history of clotting disorders. And on exam, her foot was blue. She had decreased sensation and a little bit decreased strength, and so was considered a Rutherford, acute limb Rutherford class of 2B. So I took her to the angio suite, and here's our first angiogram, and we see that, again, like my case today, there's a wonderful, beautiful profunda artery, but no superficial femoral artery is gone. And then below the knee, there was nothing. There was no flow whatsoever. There's this little teeny tiny little collateral showed up. And so, yeah, she had some clot and things here. So what we did is took her and placed a ECOS lytic catheter. This is an ultrasonic assisted catheter that infused TPA into the leg to see what, if anything, would clear up. So we ran that basically overnight, put her in the ICU, and monitored her very closely. Next day, we took her and shot a picture, and things opened up nicely, although we discovered that she did have some chronic disease right about the mid-superficial femoral artery, which we treated with a stent, and that looked great. And her runoff was actually pretty decent as well. The interesting thing, going back to this case, is that she showed up again the next year on my birthday, same day. She didn't even know what my birthday was. She showed up on the same day with the same exact problem. The cold foot, the entire leg was down in, and I saw her in the ER, and I said, guess what we're gonna do? The exact same thing. And it worked out perfect. We put her on anticoagulation after that, and so far, from what I've heard, she's doing fine. Let's bridge to carotid disease in women. The carotid and vertebral arteries are significantly smaller in women. The vessel wall is less compliant. For the same degree of carotid stenosis, velocities are higher in women than in men. Camerata now showed that all carotid segments throughout all the duplex ultrasound revealed velocities that were 6 to 9% higher in women than in men. Women tend to have more focal lesions with a greater degree of stenosis for the amount of plaque, and the carotid plaques are a greater predictor of generalized atherosclerosis in women. And again, like we said before, there is a strong link between osteoporosis and carotid disease. The indications to treat carotid disease have largely come from these landmark clinical trials that were all performed probably about 30 years ago. So it's been a while. And these landmark trials basically compared conservative management, medical management, which was aspirin at that time, to carotid endarterectomy for asymptomatic patients and symptomatic patients. And they showed a risk reduction in stroke for asymptomatic patients with greater than 60% carotid artery stenosis and symptomatic patients greater than 50% stenosis. These studies were not powered to look at a female cohort effectively. However, some trends did emerge from these studies. And we saw that carotid endarterectomy, in terms of risk reduction, benefited women less, both in the symptomatic group and in the asymptomatic group. There was double the rate of perioperative complications, and at any age, the risk for stroke was less in women. And for any degree of stenosis, it was also less. They also saw that female gender was an independent predictor of postoperative TIA or stroke. And the benefits of carotid endarterectomy for either asymptomatic or symptomatic probably need to be followed out longer in time. Going to aortic aneurysmal disease, the infrarenal aorta is significantly smaller in women, about 2.3 to 4 millimeters less. The aortic enlargement with age and decreased compliance in the aortic wall in women occurs after menopause. Aortic aneurysm intervention in postmenopausal women older than men by at least 5 years. The rupture rate is 3 times higher in women and occurs in smaller aneurysms. 34% of ruptured AAAs that result in death in the United States occur in women. However, only 22.6% of elective aortic repairs are performed in women. So we either are not offering them or not recognizing the disease as well. Endovascular treatments are less frequently offered. The aortic anatomy is different, shorter aortic necks and an iliac occlusive disease. They have more access-related complications and limb occlusion after the stent graft is placed. And they have more endoleak complications, which we talked about a little yesterday. When they do get a procedure that works, they tend to have rapid shrinkage of the aneurysmal sac, and their perioperative mortality in open repair and hospital length of stay is greater for women. So in summary, arterial vascular disease is a significant problem for women in our aging society. Their life expectancy is 30 to 40 years following menopause. We have lots more octogenarian females in this country than we do males. And in arterial vascular disease and the other diseases, aortic aneurysms tend to be underdiagnosed or undertreated. We have to know that the clinical and physiologic patterns are different in women. So the indications for treatment of vascular disease that have been derived from these large studies, where women are often underrepresented, are really not the telltale way to go about effective treatment in females. So it's our responsibility as providers to develop an expertise on natural history, disease patterns, and outcomes to provide optimal care for women with vascular disease. And again, one of what we talked about here a little bit, Dr. Harris, Dr. Sarr talked about, is the walking ABI. I think that is a phenomenal tool, especially for women who are telling you that they are asymptomatic in terms of claudication, but who are telling you that their legs have a problem in terms of functionality. So thank you very much.
All right, I am back again. When we divided up the different talks for this conference, I was very excited, like, oh, I want that one, and oh, I want this one. And then last week I realized I had 5 talks to give. So I apologize that you have to listen to me that much. But the next talk we're going to have is in following the kidney section and talk about dialysis access. So one of the things that vascular surgeons are responsible for, and now Interventional nephrologists and interventional radiologists can participate in creating fistulas. And so it's not just a surgical process anymore. It's expanded to other specialties that actually like to take care of these patients. So there is an epidemic in end-stage renal disease. We think currently there's about 400,000 patients treated by hemodialysis in the U.S. yearly. Medicare average costs are about $90,000 per patient year treatment, and this is a guaranteed spend by law for our patients. We can't not take care of patients. KDOQI guidelines recommend autologous AV fistula, followed by prosthetic grafts, and then lastly a hemodialysis catheter as the means to take the blood from the body, run it through the artificial kidney dialysis, and then take care of these patients. So the question is, what is the optimal way to take care of these patients? And there's a KDOQI life plan that Dr. Joab follows probably with all her patients. It's a PLAN, there's a patient life plan access needs, and we look at GFR and how the function of the kidney is in cleaning the body, and if it is not cleaning it adequately, then we need to start thinking about access. We're trying to avoid catheter placement in these patients, and this is why the Fistula First project kicked off about 20 years ago to help drive fistula use in the country and in the world. We think there's about 2 million plus patients globally on hemodialysis, primarily through AV fistula, which is the way that they do it. There's a lot of challenges with surgical AV fistula. 30% of patients refuse creation. They don't want surgery. Or they refuse cannulation. They don't want to be stuck in their arm 6 times a week. The maturation rate can be anywhere from 2 to 3 months in duration to mature the fistula. And a fistula is where I connect an artery and a vein together, and the vein can then develop into a way that we can put a needle in and actually access the patient. 80% of patients start dialysis with a catheter. We're trying to avoid those. Catheters cause scarring on the inside. They can have problems with infection, and mortality is different if you're dialyzed through a catheter versus a fistula. And the other problem is that fistulas fail to mature about half the time. And so there's a lot to the creation of a fistula. Oftentimes, patients can experience surgical fatigue because of the multiple interventions, the difficulties with maturation, the feeling like there's a diminishing lifeline for their patients. Because if they don't have an access, they don't live. It's very simple. Complications with catheters, we think that about 83% of patients initiate dialysis with CVCs. That same rate is here in our communities. There's a high risk of infection compared to AV fistula, higher complication rate that can lead to death compared to AV fistula, and the goal is to limit the catheter placement. So our personal philosophy at Vic and my personal philosophy is use cephalic vein first, followed by basilic, reserve prosthetic grafts for failures of all autologous access, and then and try to stay within that same arm if possible. So fistula creation. What we have to do is a vein map to figure out, do they have good veins? And then we check, do they have good arteries? And is the circulation to the hand adequate enough to sustain a fistula in that arm? Oftentimes we use a brachial artery to cephalic vein fistula. This is the brachial artery. The vein is there in the pickups. And the vein is anastomosed to the side. So it's what we call an end-to-side fistula, because we still want blood flow going to the hand. And so it has to come from the heart, down the arm, to the hand, and we steal some of that blood into the fistula. We want no more than 40% blood flow to that fistula. So it's a technical exercise to try to prevent that from happening. So this is our non-invasive ultrasound showing the cephalic vein. We can look at the flow volume through that. It's 2.6 liters per minute. Think of a 2-liter Coke bottle. That's how much goes through that fistula per minute. That's a fairly high volume fistula. We can follow this by ultrasound. We can watch for complications or problems. And we tend to get pictures like this from our technologists that show us where the velocity changes are and if there's any kind of problems. So for a basilic vein transposition, that's the other vein in the upper arm. And that vein is hidden just below the biceps. It's very rarely accessed because it's so deep. And it lives right next to the artery and the nerve. And so we really don't want to put needles into the fistula next to the artery and the nerve. That could cause some problems. So what we do surgically is transpose it. We can make an incision like this. We move that vein on top of the muscle, like you see here, where it's over top of the biceps, and then back to the artery. So this is a patient with a basilic fistula. It's a fairly high volume fistula, and you can see the incision kind of on the inside of the arm. And it can be a long-standing fistula. These are the best fistulas for patients. They tend to last the longest with the lowest complication rates. He unfortunately had, I have a patient name there, I'm going to move on. Patient had a problem with a narrowing in that area, and we had to do balloon angioplasty, and that opened the fistula adequately. Once we do that, we can manage these fistulas with angioplasty or possibly stenting if there's a problem. This is the typical location of where you're going to get a narrowing. That high volume fistula can create tremendous turbulence and pressure throughout the venous system, and the venous system responds by hypertrophying and narrowing in different areas. And so if we can balloon that, stretch that, we can keep those fistulas going. So we know that from a basilic vein fistula, we get about 12 months of primary patency. Put it in, use it for 12 months. We have, sometimes if they narrow like that, we can go back and balloon it like I just showed, and you can still get additional couple months of primary patency out of these fistula. And the question was, well, should we even do this? But the interventions in this patient population, I think it's the largest basilic transposition fistula paper out there, and I was involved with that in my training. But just that little angioplasty for that 2.6 months gave an additional 37 years of additional functional patency for the patient cohort. So it's important to try to save the fistulas. Now, fistula creation has been around for about 30, 40 years. Really hasn't changed very much until recently, where we have a percutaneous approach. And now we can use an array like this with a magnet that's into the artery and into the vein, and we can actually create a connection between the artery and the vein to allow a fistula. So this is allowing non-surgeons to actually create these fistulas, and surgeons who like to do fistula work to create these fistula. What this does is it gives us 2 additional sites in the forearm where we can create the fistula. And so we use the ulnar vein, ulnar arteries, and the radial vein, radial arteries as access sites for the fistula. But what we have to do is get the blood from the deep system up to the superficial system. And there's a perforating system that we can see right here, where the deep system comes up up to the cephalic and basilic vein, which is very superficial. You can see it right here, where that perforator comes up, and that allows us to bring the blood from the deep system to the vein where they can actually put a needle. And so it's called there's 2 out there that are currently FDA approved. We use the wavelength fistula from Bard. I do teach for them, so I do disclose that. That's about the only disclosure I have with this. And we can now create fistula percutaneously. We think it's a major advancement, and I would agree. We've performed over 100 operations in town. I think we actually have the largest surgical series in the country. This increases the number of locations for AV fistula creation. We can avoid surgical scarring and disfigurement from surgery. And it's not terrible, but it's there. It's obvious. You can see that they've been operated upon. And it does also give us a different options for cannulation. So this is basically how it works. We use a high-frequency, radiofrequency device that creates an arc between the 2 electrodes, and you have to carefully position the magnets and the electrodes. It takes about a half hour to do if you're fairly experienced, and longer if you're inexperienced. Once we access the vein and artery, we align the 2 catheters in the right position. We can activate, fire that device, and then we now have an AV fistula. AV fistulas take a while to develop, up to 2 months. And so if I can get a patient fairly early, before they actually need dialysis, we can develop this fistula in these patients. I would say from our lab and our experience, we think that greater than 90% of patients that come through the door are eligible for AV fistula creation with the wavelength device. So who's not a candidate? Well, you have to have a perforating vein. That's the elevator that brings the blood from the deep system to the superficial system. And you can't have other problems like central vein stenosis or have a vein that's actually incontiguous from the arm to the heart. So once we have added a couple other options now to AV fistula, then the question is, what are the advantages of this fistula? Well, surgical fistulas create an artery and a vein interface, one artery, one vein, and an endovascular fistula creates the connection between one artery and multiple veins. And that multiple veins, what that allows is the maintenance of flow through that fistula, and the occlusion rate is actually very, very low once the fistula is created. In addition, we don't get all of the arterial blood flow into that one vein. We have the arterial blood flow going into multiple veins. And so the pressure and the flow rates in any one single vessel is less. And so we are seeing less damage in the central venous system for these patients, and hopefully me having to intervene on them in the future can decrease. We can have a single vessel outflow like this in this one particular patient, or you can have a dual outflow. Since we have both cephalic and basilic vein attached, I can sometimes use one vessel to give blood and one vessel to pull blood. And so that's very common that you see a split AV fistula like this. And sometimes you can still use a single cephalic vein as your main source of inflow and outflow for patients. Dialysis takes about 3 to 4 hours, depending on the functionality of that fistula. And over time, the fistulas mature and become more readily available for dialysis. So a number of studies over this. We think that in the early studies, a population of about 100, the 2-needle cannulation was 85% successful at 6 months. Time to cannulation was about 1.5 months. I think that's pushing it a little bit, but 2 months is about right in my book. Reintervention rate is about 78% of patients were intervention-free at 6 months, and we have similar exposures. And then most of the patients started off with a dialysis catheter. I think about 80% of our patients start off with a dialysis catheter, and we're now trying to get them a fistula to get the catheter out. So we think it's a very high technical success rate. Cannulation is fairly quick by 6 months. Primary patency rates are good. The potential benefits are avoid surgical scarring, can be done by multiple different types of physician groups, expands the number of locations for fistula creation, and then can be done under regional local anesthesia instead of general. So thank you very much.